All right, your next witness.
Your Honor, we would like to call Dr. Don Hughes to the stand
All right,
again.
Dr. Hughes. Thank you, Doctor. Just a reminder that you're still under oath, okay, ma'am?
Yes, Your Honor.
Thank you.
And could you please just remind the jury who you are again?
Sure, I'm a clinical and forensic psychologist. I am board certified in forensic psychology. I am the president-elect of the trauma division of the American Psychological Association, and I evaluated Amber Heard over 6 visits for approximately 29 hours.
Okay. And why are you here today?
To offer a rebuttal testimony to Shannon Curry's testimony of yesterday.
Okay. Now, Dr. Curry said you used improper methods. Would you agree with that?
No, I would not.
Why? Please explain.
As I testified to you all several weeks ago, I used a standard forensic procedure that is well established in our field. It is a multi-method, multi-hypothesis-driven procedure where you're looking at a variety of different details and tests and external data to arrive at an opinion, and you're looking at the consistency across that data. There are 3 sort of sets of tests that we use as forensic psychologists, and I think that's where it seems that Dr. Curry seems confused. We have forensic assessment instruments. Those are instruments that are very neatly tied to a legal criteria. Those are most notably done in a criminal court for competency. If someone has competency to stand trial, we have very clear measures that can track that legal criteria. The next level are forensically relevant instruments. And those instruments are not linked to a specific legal criteria, but they do have information that's germane to that finding. And that can be an example of a risk assessment measure and a malingering measure. So the malingering measure that I utilized was the MFAST, and that was the only malingering measure in this case. The third category are clinical assessment instruments, and those are instruments that are validated and well-researched and used in the clinical realm as we understand people's symptomatology and diagnostic and functional capacities. Those are things like the MMPI, the PAI, the CAPS, the TSI, because they are clinically relevant and they still give us very valuable information to individuals who are involved in a court case. And the reason that we do that and we use these clinical measures is because the majority of the people that we see are in a clinical realm. They're not in a courtroom. So they're well-validated and well-researched methods. What we also do is use a very different types of tests within that category. We use some checklists, some face-valid checklists. We use some tests that are those broadband personality inventories. We use structured clinical interviews. And then we look for the consistency across those data points. And when we use different types of tests, it gives us information about the individual, how they go about these tests in these different modalities.
Now, Dr. Curry seemed to suggest that Amber Heard tested the most extreme category in all of these different tests. Is that accurate?
Objection, compound.
Overruled.
That is not accurate. They were not on the checklist. I mean, people sometimes do. They go, all the time, this happens to me all the time, frequently. And that is not how she endorsed these tests. She endorsed them in a very moderate way, in a very nuanced way, describing her symptoms that I determined was accurate and reliable.
Now, Dr. Curry also suggested that Amber Heard was tested very, very high, 98th percentile, I think, on malingering and feigning. Could you speak to that, please?
Sure. So, I mean, she said a lot of things, so let's go through those tests. The first was the PAI, and that's that other broadband psychological
Objection,
measure.
non-responsive.
I think it's very responsive.
It's sustained.
Okay. Could you tell the jury about the PAI test that Dr. Curry
Yes.
addressed?
So, yes. Thank you. So that's the broadband measure that has validity scales built into it that gives us indications about how the individual goes about the test. I told you last time that there was no evidence of malingering or exaggeration or feigning on that test. What Dr. Curry was talking about was this tendency to put your best foot forward to minimize faults on this PAI. That scale was right at the cusp. And then there are two other measures that we look at that to say, is this enough for an elevation for me to consider that as a serious response distortion, of which Dr. Curry was saying, and it was not. What was relevant on this test was there were elevations on anxiety, on affective anxiety, meaning anxiety, tension, worry, on traumatic stress, on hyperactivity, and on affective instability. Those were the 4 scales that were elevated on this test. The borderline scale was not elevated on this test. And this test...
Objection, Your Honor. May we approach?
Yes.
So Dr. Curry, let's move to the TSI-2. Dr. Curry testified about your findings on that. Did you agree with her testimony yesterday?
No, again...
Please describe why. Explain why.
What Dr. Curry went back to, which is this 98th percentile, which I told you in the manual. All you have to do is read the manual. It says specifically that we do not use the percentile ranks for this test. That indicates to me that, Dr. Curry does not know the psychometric properties of this test, and that she then is therefore not qualified to interpret it. That score, the one that's elevated, which she's talking about, that percentile rank, has a raw score. Amber's raw score is a 10. The cutoff score is a 15. She's nowhere near that level of exaggerated symptoms where I can't further look at that test. Secondly, there are 3 scales out of maybe there's about 20, a little more on the TSI that were elevated. Intrusive experiences, that's when thoughts and memories of the trauma come into your mind when you don't want them. Defensive avoidance, sort of behavioral ways that we try to push out those memories and not think about them. And then relational avoidance, a way of having difficulty in interpersonal relationships. Those are all trauma-based symptoms, and those were elevated on this test.
Thank you. Dr. Hughes, the MFAS, Dr. Curry addressed that as well and had criticisms for your interpretations. Do you agree with that?
No.
Please explain to the jury.
So the MFAST, as I told you last time, is a measure of malingering. It's the only measure of malingering that was done in this case. Dr. Curry did not independently administer a measure of malingering, and there are other ones that she could have done to augment her evaluation. And she kept saying something that MFAST is not for malingered PTSD. That's wrong on a couple levels. People who are going to malinger and feign don't only feign one diagnosis. They sometimes talk about all different symptoms that they have, and they exaggerate and they make themselves seem much worse than they are. So when you're doing an evaluation, you're giving a malingering measure to get a sense of how this person is responding to this evaluation. Now, what you do is you take those 3 tests that I talked to you about, the PAI, the TSI, and the MFAST, all with valid validity scales, you have greater confidence in your results. And that is in the literature, and that's literature that Dr. Curry cited in her report. That bolsters the methodology that I used. That in a study that had the PAI, the MFAST, and the TSI in the title of detecting feigned from bona fide PTSD.
Thank you. Now, Dr. Curry also talked about the danger assessment scale and suggested that you had inappropriately interpreted that. Do you agree?
That's also incorrect.
Please describe for the jury.
Which I told you last time, the danger assessment scale has statistically validated risk factors for serious or lethal domestic violence. Those risk factors exist whether we go forward, we're sitting with someone in an acute setting and assessing them right now, or if we look backward and we look retrospectively about what factors may have been present in a case that indicated severity. That instrument is used in what we call, there's called domestic fatality review boards. Those are boards after somebody has been killed, a homicide has occurred in a domestic situation. They look at these risk factors to see what was there and what could be done.
Right. Dr. Curry also criticized your administering of the CAPS 5. Do you agree with her criticisms?
I do not.
Will you please explain to the jury?
So the CAPS 5, as you all have heard multiple times, is a structured clinical interview in determining PTSD according to DSM-5 criteria. On this measure, Amber Heard scored in a moderate range. She did not over-exaggerate on this test. She could have said no, mild, moderate, severe, and extreme. All of hers were either 2s or 1s or 0s, not above that. So she's scoring in the moderate range, which still has functional impairments. I mean, we don't want someone to be having moderate PTSD, but that's not an exaggerated profile or an exaggerated response style of someone who's answering an instrument.
Right. And the last of these Dr. Curry referred to was the PCL-5. Do you agree with her criticisms of your administration and interpretation of that?
No, so the PCL-5 is a checklist of symptoms of PTSD. It is, as she said, it is a face valid instrument. It means it's very clear about how you can endorse this. But what the person has to do is say, how disturbed am I by these symptoms? And when you have face valid measures with these other measures that have the built-in sort of ability scales, you're sort of controlling for that response bias error. You're controlling for that individual to sort of over-exaggerate. But then what you do with that test, because this is, we're not just administering them like robots, is you go and you do a clinical assessment. And that's what I did. I took what she wrote, what she endorsed on that test in January of 2021, and I did a clinical assessment of those symptoms to see if they meet criteria for PTSD. That is something we do clinically, and I do in my office all the time. And yes, she did meet PTSD from that in January 2021.
Thank you. Now, Dr. Curry said you misinterpreted her test results. Do you agree with that?
Yeah, I agree that I agree that I interpreted them, that she misinterpreted them.
Okay. And please explain that.
Yes. So I said that before. My stance on the MMPI and how she interpreted it is, I believe, wrong, and I think
Objection, Your Honor.
All right.
That's the issue we just addressed.
All right.
I don't.
If you want to approach.
Now, Dr. Hughes, Dr. Curry also testified that a victim of PTSD has to effectively be prone and unable to function at all. Would you agree with that?
Objection misstates the evidence.
She said they couldn't hike, they couldn't move, they couldn't function in any way, shape, or
Overruled
form.
objection.
Thank you.
No, that is not correct. That is often actually a myth and misconception about individuals who are struggling with PTSD or trauma-based disorders, and I'm often called to answer that and speak to that. People who are struggling with trauma and PTSD are very strong, courageous, resilient people, even though that they're struggling. They get up, they have to go to work and drop their kid off at school and go to the market, even though they're struggling with these symptoms. So I often talk about it as this sort of walking around with a 50-pound bag of flour on their backs, just sort of trying to get through the day, where sometimes that button's going to press play and the trauma's going to start start activating in their head, and then they're going to be having to think about it and have startle and have physiological reactions until they can find a way to hit that pause and shut it off again. So they still have, impairments in other ways, but they go about their lives. They're not, totally debilitated. If you have someone in that high range, the highest score is an 80 on the CAPS, Ms. Hurd had a 28. If you have someone in the higher range, we have seen people who are, severely disabled because of it, but that's not the norm of people who have this moderate PTSD.
And did you find functional impairment with Amber?
Yes, I did.
Now, Dr. Curry also said that it is not within the scope of a psychologist to evaluate domestic violence. Do you agree with that?
Of course, I don't agree with that. This is what I do for a living, day in, day out, for 25 years. We are specifically trained to understand the profound impact that trauma has on people's lives. That's what we do in the trauma division of the American Psychological Association. We disseminate that knowledge. And domestic violence is one of those profound traumas. Domestic violence is part of state licensing boards, that you can't get licensed in some states unless you take training on domestic violence. You can't renew your license unless you get training on domestic violence. So people who have, specialized training in this area, it is, beholden upon them to accurately assess for intimate partner violence and sexual violence. And it's more important to assess for this sort of scientific understanding of what domestic violence is. So you have to assess for the physical violence, the psychological violence, the surveillance, the economic, the emotional abuse, and the sexual violence. That is not gratuitous. That is
Objection.
understanding.
Narrative.
All right. Next question. Let's take a question.
Okay. Now, Dr. Curry suggested that you made a determination just based on personal opinion and just on checklists and a couple of tests that you misinterpreted. Would you agree with that?
I vehemently disagree with that. As I stated to you, over 29 hours and 12 psychological tests and reviewing a slew of documents in this case, most importantly, therapy records and interviews, collateral interviews with therapists. Using all that data, that is what a solid forensic methodological exam looks like. And then I made my conclusions based on my clinical education, knowledge, and training to come up with a professional expert opinion.
Okay. And just to remind, to make sure we're reminded here, you were qualified in this court, in this case, as an expert in forensic psychology, specifically in domestic violence and in no, I just lost it. And in violence, correct? Intimate and in trauma, correct?
Objection, Your Honor, misstates the record.
Yeah, if you want to ask the question again.
Yeah, I probably should do that. You were qualified. I got to find my note. You were qualified as an expert in forensic psychology with a specialty in domestic violence and in trauma, correct?
Correct.
Okay, and that was in this case?
That's correct.
Okay. Now, do you still hold the same opinions you did that you gave the jury earlier?
Yes, I do.
And do you still hold them within a reasonable degree of psychological probability and certainty?
Yes, I do.
Thank you.
All right, cross-examination.
Yes, Your Honor, but can we approach quickly?
Sure.
Good morning, Dr. Hughes.
Good morning, Mr. Dennison.
The last time you were here, I believed that you testified that you had diagnosed Ms. Hurd with PTSD before you gave the gold standard CAPS-5 test.
That's correct.
Right. And that diagnosis is actually reflected in the first of the disclosures you put forward in this case.
I believe the first disclosure was February 2021, and at that point I had done 11 psychological tests. That's correct.
Right. And your disclosure reads, Ms. Hurd's responses on the PCL-5 support a DSM-5 diagnosis of post-traumatic stress disorder with an etiology of intimate partner violence she experienced by a former partner. You remember writing that?
That's correct.
Okay. You just testified that you need to read the manual, right?
Yes.
Okay. Can we put up 1311 as a demonstrative?
Any objection to
I don't know
1311?
what it is, Your Honor.
All right, if you want to
Maybe we
leave,
approach.
you want to approach?
Tom,
Thank you.
I don't see this in my document either.
They're getting the right one up.
yeah, we got it up. Let's use 1312.
1312, okay. And that, any objection to that demonstrative?
No, Your Honor.
Okay, 1312 can be published to the jury.
Dr. Hughes, do you recognize what the National Center for PTSD is?
What it is?
Yeah.
Yes, I do.
And they publish the PTSD checklist for DSM-5,
That's correct.
that what we've been calling the PCL-5.
Correct.
All right. And do you, are you familiar with the document that's on your screen?
Yes.
All right. What is it?
It's the instruction manual to how to administer the PCL-5.
Okay. I'd like to move for the admission of 1312.
Any objection to 1312 coming into evidence? All right, 1312 in evidence.
All right. Can we go to the second page? Can we blow up the second paragraph on the right? That's the PCL-5 should not be used as a standalone diagnostic tool. When considering a diagnosis, the clinician will still need to use clinical interviewing skills and a recommended structured interview, e.g., the CAPS-5, to determine a diagnosis, correct? That's what the manual says.
Right, and this manual
Okay.
also says that this is a screening instrument, so when you do the clinical interviewing, you absolutely can determine diagnosis
So the
after
answer is
somebody
yes. The manual says you
still
that
need
the
to use clinical
PCL-5
interviewing skills, which I used.
Well, let me finish my question. The PCL-5 should not be used as a standalone diagnostic tool, and they recommend using the CAPS-5 to determine a diagnosis, correct?
It does say that, yes.
Yeah, and you made your diagnosis before you did the CAPS-5.
I made my diagnosis doing clinical interviewing and 11 other psychological tests that supported diagnosis of PTSD and symptomatology consistent with PTSD.
Okay. you said that we should read the manual. Would you also agree with me that we need to read the directions on these tests?
Sure.
Okay. Tom, can you pull up 1309 as a demonstrative?
Yes, sir. Thank you. Any objection of 1309 as a demonstrative?
May we approach?
Okay. Nine and publish the jury as demonstrative.
Doctor, do you recognize the demonstrative that's in front of you?
Yes, but I didn't put the red lines on that.
No, I did.
Yes, I know.
Okay. So this, what do you recognize this as?
I recognize that we previously discussed this, and I told you that I oriented Ms. Hurd to a different time frame because she was already out of the relationship.
Okay, maybe we should back it up a little. This is the CTS-2 that you administered as part of this battery of tests that you indicate you did in relationship to your diagnosis.
Right, this is the conflict tactic scale 2.
All right. And you'll agree with me that this test specifically asks, in front of every single question, how often did this happen in the past year?
Correct, and I
Right.
oriented
And
the
you
individual
know-
to not
I-
limit herself to the
correct.
last year to get an accurate assessment of the violence and abuse that she experienced in the relationship.
Objection, Your Honor, move to strike.
All right. I'll move to strike the last part of the answer. Strike the last part of the answer. Thank you. Next question.
Yeah. And you know that at the time that you gave this test to Ms. Hurd, she had been away from Mr. Depp for far longer than a year, correct?
Which is why I oriented her to a different
Yes or no,
time
ma'am?
frame in answering the questions.
Doctor, yes or no?
So, of course,
Okay, you knew she was gone for more than a year.
of course.
All right. Let's look at another one of these. You talked about the danger, I'm sorry. You talked about the danger assessment test.
That's correct.
All right.
What number is this? 13, plaintiff's 1310.
Thank you.
Any objection to 1310 as a
No, Your Honor.
demonstrative? Okay. You publish to the jury.
Dr. Hughes, this is a blank form, but this is the danger assessment test that you also gave to Ms. Hurd, correct?
I didn't give it to her. I filled it out based on the data that was provided to me.
Oh, so you asked her the questions and then you filled it in.
It was somewhat collaborative.
Okay. Can we blow up the second full paragraph? It says, using the calendar, please mark the approximate dates during the past year when you were abused by your partner or ex-partner. You didn't use any calendar, did you?
I did not use a calendar because she was already out of the relationship. As I said, these are static risk factors, so they don't change. So I
But these
oriented to the
exams-
time of the relationship.
Ma'am, it's fair to say that this examination that you gave specifically indicates that you were supposed to look over the past year. And that's not
one,
the language?
no, that's one administration. People use this instrument for if you're in an acute situation in a relationship, trying to get a better assessment of the current behaviors. We can use it retrospectively, like I just stated, and in homicides and looking back about what are the serious risk factors that were in this relationship.
I didn't ask you about anything other than, don't the instructions limit this test to the previous year?
You can give this test not only on the previous
Nope, asking
year.
you about the instructions.
But I'm telling you how the test is administered in clinical practice and in forensic practice.
And opposing counsel can come up and ask questions about it. I'm asking you about the instructions. And the instructions say, look over the past year.
Yeah, on this, yes, it says that.
And you had actual knowledge when you gave the test that Mr. Depp was gone way more than a year before this test.
That is correct.
Right. All right. Let's look at more instructions. Can we look at 1247, which is already in evidence? Dr. Hughes, you recognize this one too, right?
Yes,
All right, this is what everybody calls the CAPS 5.
correct.
All right, can we go to the first page? Let's blow up the instructions. Standard administration and scoring of the CAPS 5 are essential for producing reliable and valid scores and diagnostic decisions. Correct?
Correct.
And you have to do this in a standardized way because it is the first instruction, correct?
Correct.
Can we go to the next page? One more. Oh, wait. That's good. This is a page on scoring, and we talked about this last time.
Yes.
You score these tests by frequency and intensity.
Correct.
And you'll remember that in every single instance that you were asked to fill in the blank about frequency, you failed to do so, correct?
That's not correct.
Oh, you filled in any blank on this form with respect to frequency?
I filled in the frequency on the side of the caps where I am actually scoring the caps.
No, I asked
Where
you
it's
whether
relevant.
you filled in a single blank on this form with respect to frequency. Is the answer to that yes or no?
I don't know what you mean, a single blank.
All right, let's page down. Let's keep going. All right, we'll stay at this page for a second. This is the very first box you're asked to fill in as to, I think, a fairly fundamental question, right? What happened?
We talked about this before, Mr. Dennison. I had 88 pages of notes of what happened. It would have been redundant to put it there.
You know that you are obligated to produce this test in a way that other people can meaningfully review them. Yes?
The people in this case who are meaningfully reviewing them have my 88 pages of notes.
All right, but you chose to put absolutely nothing in the box, the standardized box, that said what happened.
You don't have to put it in the box if you have it somewhere else. It's not
Because
a,
this
if
is
it's
not
not
a standardized test?
Well, if it's not a research instrument that is used for research, if you're using it for a clinical diagnostic purpose, no, you don't. If you have that data elsewhere.
Okay, let's go another page or so. All right, let's go another one. All right, let's look at item 4B4. And I asked you whether you filled in the blank about frequency. And there's a blank in many of these items that asks number of times. You didn't fill a single one of them in, did you?
Right, because I filled them on the right side of the instrument where I am scoring it.
And that is the way that you believe that you followed the instructions of a standardized test.
Yes, correct.
No further questions.
All right, redirect.
Very briefly. You used the term static risk factor. What did you mean by that?
Static risk factors are risk factors that don't change. It's maybe if you smoke cigarettes, you may have a risk of lung cancer, right? That's a factor that doesn't change. You can look forward if someone's smoking, you can look past if someone's smoking. So these lethality risk factors are present whether you're evaluating them in the last year or 5 years ago.
And when you're trying to assess for trauma related to the interpersonal violence that we discussed, why is it important to get a time frame in which the relationship was in existence?
Well, you want to see the amount of trauma that the person experienced. The longer that they're in a relationship, you have more successive trauma. And one of the things that we know from the research is more trauma is not better. So the more successive traumas that you have, the greater likelihood that somebody's going to have psychological consequences and symptomatology as a result.
And therefore, you need to get it within the relationship.
Objection leading.
And so how does that relate to needing to get the time frame in the relationship?
Well, you need to understand when you're trying to evaluate the impact of something, you have to understand what happened to the person. And that's sort of the core and the basis of trauma-informed care and of trauma diagnoses. You have to understand, the traumatic event and how it transpired and how it played out for that individual so that you can better assess for the symptomatology that's falling from it.
You said you had 88 pages of notes. What were in your 88? And without going into the specifics, can you just describe what was included in the 88 pages of notes?
In the 88 pages were many of the documented incidents of intimate partner
Objection, Your
violence.
Honor.
She's just describing it. That came up. He said you didn't fill those in the boxes. She said it was in my 88 pages. I'm just saying what was in your 88 pages. I'm not asking her to give each of the specific events. She can describe the summary of it.
Can we come up?
Okay.
What is the difference between clinical scoring and clinical evaluation and research evaluation with respect to the CAPS-5 and the other tests?
Objection compound.
Sustained.
Your Honor, when it's compounded, it's because it might be confusing to the jury.
Good. Sustained. Next question.
Okay. Can you explain to the jury what the difference is between clinical scoring and evaluation on a test and research?
Objection, Your Honor, compound.
Overruled. Good.
Sure. So the PCL and the CAPS-5 are frequently used in research. And when they're used in research, that means the document stands alone. They don't have 88 pages of notes to help understand the background of the trauma and what the person has experienced. And why those boxes may be relevant in research is because back in the day when I was a research assistant, I had to input that into the computer. And then they would maybe look at some of that data for the research study. So that becomes very important in research.
All right. Thank you. I have no further questions.
All right. Thank you, Dr. Hughes. You can have a
Thank
seat in
you.
the courtroom or you're free to go, okay?
Thank you very much.